So our first question this morning is what was the specific reason that you chose a career in nursing? And Menshu, we're going to start with you here.
Oh, sure. Well, thank you so much for inviting me on this opportunity, first of all. Basically, the first thing, when I was in my high school, we have this career guidance thing. So actually my desire is to be a doctor. But then, based on my family, poverty is really common. So I have like more siblings to go to college. So I went up to this nursing career guidance and I saw it and I just fell in love right there. So that's what made me going. And
what did you fall in love with?
The nursing wise, being with the patient and communicating with them from day-to-day lives on their weakest moment, but you are there and were able to give them that hope. It's just amazing and it's priceless feeling for me.
Great.
And I will continue to do that.
Kelly, what about you?
My mother was diagnosed with cancer when I was 15.
Okay.
And I really looked at the nurses and what they did for the patients and our family, and that's what I wanted to do. So that's one of the impetuses of me going directly from high school into college and nursing.
Great. Jude?
I grew up on a farm in North Dakota, and I was injured when I was about 3 years old, quite severely, and was brought to a hospital, had to stay there. And my mom tells me that I was deathly afraid of nurses and anybody in white, because they all were white then. So for a while after that, anybody saw anybody in white, I would scream and not want to be near them. And then ever since I can remember, though, I wanted to be a nurse. And so I think maybe that somewhere along the line a nurse comforted me when I was in the hospital, and that stuck with me, and I've always wanted to be a nurse ever since I can remember, even though it surprised my family because they said I was scared to death of nurses and doctors when I was little.
Nancy?
Well, I knew that I wanted to go into like health sciences, like Menshu. I wanted to help people, and I was very excited by medicine. And the science of medicine, but I didn't know what I wanted to do. And so I do remember my mother saying to me, be a nurse. You can do anything. You could be a nurse and you can be a lawyer. You can be a nurse and a photographer. You can be a nurse and you can be anything. So just be a nurse, and you'll always be able to take care of your family, and you'll always have a job to fall back on. And while that's a little bit cliche, it's true. Mm-hmm. And it didn't hurt that my mother is a nurse, and 5 of my 6 sisters are nurses as well.
Wow.
So it was almost a destiny.
Okay.
Yeah.
And Karen? Last word on this one.
Well, yeah, actually all of my family at one point worked in the hospital, except for myself. And when I was 18 working in retail, my mother said to me, you will come to the hospital today, you will apply to be in the secretarial pool, and you will become a nurse. And so I came to the hospital, I was in the secretarial pool, and I actually got to observe nurses with patients and their families. And for me it was kind of a realization of the privilege and the pleasure of being with people in such an intimate setting, that was kind of my calling, if you will.
Great. So I've read that nursing is one of the most trusted professions, even ahead of doctors. What is it about you and about nursing that the patients trust? And Menshu, this question is for you.
Yeah, I believe it's our presence, because we're there 24/7, actually. We're there for this worst moment, and basically the doctors, they're there, but we have to call them, but we're the first-hand person that they can rely on. And I think that's what it is, that is very important, because we are there to advocate for them.
Mm-hmm.
Yeah.
Does anybody want to add to that?
I would just add, I think nursing is a profession that's very relational and physically, in a physical way with the patient, because you're physically taking care of them, and I think because of that relationship, patients trust you, and you have to do it in a way that's very respectful, and you have to interact with them on an intimate level, and I think that builds the trust on a different level than it does with any other healthcare professional.
Mm-hmm.
Anybody else, Karen?
Say too, yeah, you're at a point in their life with them that they're having a monumental change in their life, and everything that happens, is something that they'll never forget, and you are instrumental in making that difference in their outcome and in that experience when they're in the hospital. You really are that liaison between advocating for the patient and then relaying the information to the physician and coordinating that care and getting that patient back to where they possibly can be in the best way, not only emotionally but physically as well, if you can also offer that.
Okay. You were going to add something?
Yes, just one personal story. My daughter was a patient in the hospital last year. She had major spine surgery. And I've known nursing forever. My mother was a nurse, as I said. And I was taken back by how important it was for her to know who her next nurse was every shift. That would be the question she would ask. Can you find out who my nurse is? Is that nurse going to come back and take care of me? It was such an important thing for her because, just as you shared, it is a personal relationship, and the amount of touching and healing that allowed her to do was really impressive to me. And I've seen it from the other side, and so I got to sit back and watch at how important it became to her as a patient.
So the audience for our publication is a business audience, and healthcare and health reform is very important. I guess, Nancy, the question that I'd like to ask is, what role do you see for nursing in the implementation of healthcare reform?
Well, I think with health reform, we see more and more changing with the payment programs. So
what does that mean?
That means that where we used to get paid by almost anything that happened to a patient, so if a patient went home and came back and was readmitted, we would get paid. Or if a patient was in the hospital and something happened to the patient, like they fell down and needed an operation for that fall, we would get paid for that. We are moving into a place where payers are paying for value. So they're paying to keep patients safe. The model is changing very much. And really, the people, there's such complexity to that of making sure that every patient is as safe as absolutely possible, and when they leave the hospital, that they stay out of the hospital. That the nursing role is absolutely integral to that. So the nurse is the real, as we've been mentioning, the nurse is at the bedside. So the nurse is the one that keeps the patient the safest. They're really the gatekeeper, if you will, for safety. And nursing roles in the home are changing. So there are more and more roles for nurses to assess homes, to make sure patients can get home, that they have their discharge medications at home, they understand them so that they're not coming back into the hospital unnecessarily. So I see the role for better efficiency, more knowledge about safety and safe practices. So I really see that the nurses, and I know at O'Connor, they're working very hard and are really the face of safety for that patient.
Anybody else want to add to that? Yes, Menchu.
Just for an example, we are all aware about the pay per performance. So basically, our bedside nursing, our staff are really more educated on, we got to make sure that each patient are really satisfied with the care we are given. So we have so many projects. We're doing that, to make it more better every now and then. And we've been trying to, or actually we're doing to have more staff get involved, to be very eager to learn more on how to keep that happen. So we have a continuous education on each staff and continuous project, and we do some patients rounding. We do that, and we ask them about how they stay, and really make them more satisfied of the care. And if there's something wrong, we usually right then take care of that.
Can you explain a little bit more about the pay for performance?
I think Nancy, that's what basically
Nancy,
is related to that.
Yeah. Well, I think that the pay for performance is that the government, CMS,
Right.
Is withholding a certain amount of money from every hospital, and you earn that money back based on your quality and safety scores.
Oh, okay.
And your patient experience scores. So you get a percentage of money if you are delivering evidence-based care 100% of the time.
Okay.
You get paid a certain amount of money if you have safe practices, and you get it paid, and patients don't die. A certain percentage of patients don't die in your hospital. And then you get a percentage of money based on how patients experience, not satisfaction, but what was their experience in the hospital? How well did nurses communicate to you?
Okay.
How well did nurses communicate? How well did nurses communicate every time you got a new medication? And how well did you understand? Did the nurse? I think did the staff do everything they could to manage your pain? So pain management becomes the experience of the patient, and again, this is where nurses not just have to give them pain medicines, but have to make them understand this is everything that we could do in the hospital to make you better. And so that just creates a whole world of a creativity around how to make that the best possible experience for a patient while being the safest.
So Judy, how is O'Connor equipping nurses to, I guess, provide a better customer experience?
Well, I think nurses are traditionally trained to be patient focused.
Sure.
And focused in having the responsibility to improve the health of the patient. And at O'Connor, we actually, through a Gordon and Betty Moore Foundation grant 3 years ago, we got involved with, it's called Integrated Nurse Leadership Program.
Yes.
Which is helping nurses at the bedside learn how to be leaders and learn how to be change agents, quite honestly. And so we've trained them and taken this group of nurses some from every unit and trained them on those principles. So setting goals, using evidence-based practice, care, gathering data, analyzing data, tests of change, and then measuring outcomes. And so with that process, and also coaching their peers to be compliant also with evidence-based practice. So that process has helped us to improve our care, improve our outcomes, and really bring a whole new dynamic to the way nurses are looking at their care, not just at how well they took care of that patient that day, but what is the outcome they're getting. Pardon me. So that process has happened. And an example with that, with the focus that we took starting this project, was reducing sepsis mortality. And so we've, at the time, about 3 years ago, it was about 19.6%, and it's down to about 12% now. So what that means in real life is that this year we've probably saved over 60 lives at O'Connor because of that program, and changing the outcomes and the whole improving the health of the patient and the care of the patient. So those are the things we're doing at O'Connor, and we're expanding it actually to other quality outcomes and customer service, patient experience outcomes as well, that process.
Did you want to add to that,
Yeah,
Kat?
we also look at hospital-acquired infections. Sometimes patients will come into the hospital and they acquire an infection from a catheter, urinary catheter. So a project they were taught this model to influence change in their peers, and it was staff-led in the ICU, and they reduced Foley catheter, they have it to a 0 rate. And they did that by education, interdepartmentally. They spoke to the ER, they spoke to physicians, and the important thing is what's the best that we can give our patients. And that was their prime focus when they were going after the target of 0.
So if I could circle it back to health reform, in the old
Sure.
days we used to have a quality department. And the quality department was charged with improving the quality of care. But if in this model, to be able to really affect change at the bedside for every patient, the concept is to teach improvement methodology to the front line, teach it to more people so that they're embedding it right in their work every single day. And then you have 1,000 people in your quality department instead of a focused, siloed department.
Right.
And I think that is the way to really affect not just, health reform in the way it was intended, which is to make a better model of healthcare. Not just a different payment system, but a different model of healthcare.
Is it, and this question is for all of you, is it hard to get new systems put in place in a hospital? A hospital's it's a big operation, and the example that you've just given is something that was staff-led. Mm-hmm. Is it hard to get everybody on board to make that happen?
Yes and no. I think
it's a very safe answer.
we've always done things this way, so we need to continue doing it this way. That's our biggest barrier. The next is how to get them to change, is just to show data. They truly are scientists at the bedside, as Nancy was saying, implementing changes, and data speaks loud. So through that, we've been able to implement quite a few changes.
And something else I've been working on as advanced practice nurse for the stroke program is identifying what we call stroke nurse champions on each shift on our stroke unit, and then every day I round with those nurses at the bedside with the patient, and we take it a step further like scientists. I review the neuroimaging with the staff so they can see the location of the stroke and the patient. We do a bedside clinical exam with the patient. We go over all of our core measure, all our prevention, and we really focus on education to prevent them, ideally, from coming back to the hospital, but to ensure that they have the resources that they need upon discharge. And that's been quite successful as well. And the nurses are thrilled to see the neuroimaging,
Sure.
the CAT scans, the brain MRIs, and those kinds of things.
And some of the change that's occurred around education is what we call pushing the envelope, is starting that education at the beginning of the patient's stay, and any printed information goes into an envelope, and we make sure that envelope stays with the patient regardless of what department they're in.
Wherever they go.
Wherever they go. If they start in ICU and then they go to med-surg, that goes home with them. So that we reinforce
Okay.
the education
Okay.
through written materials and making sure that they understand. You probably can speak
Yeah.
to that a little bit.
And so, because there are some patients that comes from different department and
Sure.
goes to a different department, right? So when they come to us, what we've been doing when it comes to medication, communication with medication, is we encourage every staff to really communicate well with the medication, with the patient before giving the medications, even if they don't ask. Just kind of, explain it, what they're taking, what to expect, and how to call the nurse for any reactions of this and that. And so far we've been doing really great with that. In each room we have a post right there. We call it educate before I medicate. So we've been doing that. So it's really good. I mean, there's some at the very beginning that's very that's normal. There are some that don't want to do it, but eventually they've been doing great. So it's been good so far.
So I want to talk about technology for a minute, and Judy, this first question is for you. We've heard a little bit, this morning about the importance of technology and change. What do you think is the next big thing for the relationship between technology and healthcare?
Well, most hospitals, including O'Connor, has an electronic health record, and barcode medication administration, which is improves patient safety, reduces errors, etc. The next big thing at O'Connor is we're rolling out CPOE, which is computer physician order entry, where the physicians, instead of writing orders in a chart, put them right into the computer system, which is also proven to reduce medical errors and duplication of work and tests, actually. So the next big thing I think that really has to happen is integration of all of these computer systems, because physicians have computer systems in their offices, and we have a computer system at the hospital. Many computer systems at the hospital. Insurance companies have their own computer systems. So I think the next big thing that has to happen for improving communication and efficiency and coordination of care is integration of all of these systems, which is a big challenge, because having all these different systems interface is difficult to do, but I think that is the next big thing that's going to happen. And then I also think that there's a lot of actual diagnostic equipment and treatment equipment that is computerized as well, and having all of those interface with all these electronic record systems has to happen. So it's driving data into the system, and I would like to see it actually be able to not only give information into the system, but help the nurses and help the physicians have alarms built in, so that, because there's so much data called big data.
Right.
There's so much big data anymore that it's really difficult for the nurse to keep up with all of that. And so if there's ways that you could get, red flags and alarms that would help, say you have to look at this, you have to respond to this, that's another thing I think that's really going to have to happen.
Okay.
And my biggest fear with technology is that that nurses don't get so caught up or have to spend so much of their time taking care of the computer and take care of technology that they're having less time with the patient. Because nursing is about the relational interaction with the patient. And so it has to be user-friendly, it has to be fast, and we have to keep nurses at the bedside. And it's a big challenge.
Does anybody else want to jump in on that? You covered a lot with that answer, so I want to make sure.
I think it's a generational issue.
I think the younger nurses are much more proficient at computers than people my age or older. It's just not how they were taught to do things. They still want to write everything down and then go put it in the computer. Where the younger nurse, the millennium or the Gen Xer, will just start typing as they're with the patient and able to just have that be a piece of equipment while they're taking care of the patient.
So is that millennial or Gen Xer, while more proficient at the technology piece, are they as good at the relational piece?
Some aren't in some, and you lose some of that too.
Sure.
Yeah,
Don't you?
I think so. I think I'm on the general theme because I mean I can manage, but my experience basically is I still want to make sure that my patients are really taken care of before I'll do my computer stuff. I mean that's very important. I don't want to lose that, and I think it's really more on the age. I think so, but there's still a lot of nurses over there that they were able to manage that.
Mm-hmm.
So I mean, it's probably going to be a big deal someday, but later on it's going to be really fine. But it's normal. And anything new, there's always a challenge. But it's the consistency and the persistence of the nurse, and making sure that the patient is always on top of everything.
And ease of use. And so we do have nurses that are part of the development of what it is they're documenting, so that hopefully the ease of use will make it more acceptable.
So are some of the systems that need to be employed to get all of the software specifically to talk to one another? I mean, is the hospital's got one set of computers and the doctor's office has another set. Who's creating the way to get that technology to talk to one another? And is some of that coming from the staff up, or is a lot of that coming top down?
Both, I would say.
Both? Okay.
We definitely have nurses at the table making decisions, giving input into what works, protecting basically their workflow and their patient workflow, and making sure that it's the system's adapted to that, not the other way around. And but I think we have a group of physicians that are also involved at the table making decisions about what works for them, and so it's coming from all of the different disciplines as far as how to do this integration. And some physicians are they're in our IT department. It's from our system office actually. The plan is to have this integrated system where physicians and hospitals and all of us have a way that we interface and communicate together on that to the record, the medical record, as well as to each other through this electronic system. So it's coming from every angle.
And the flow of information follows the way your system is structured. So we have a greater alignment strategy because in the last year, it's only been about a year that we've now have a Daughters of Charity Medical Foundation. So in that way, we can start to align some of the communication between the office and the hospital better. So that's a better strategy. But to the extent that patients go different places,
right,
that information still isn't completely solid with them. So what would be great is if a patient was carrying around their information and you could tap into it as they went from one setting to the other, but we're not quite there yet.
Okay. So, California Valley and the Valley are very diverse, and you deal with lots of different patients. And so, Kelly, this question is for you. How do you prepare to take care of people from so many different places? And I'd actually like to hear from everybody on this, but Kelly, we'll start.
I think we're fortunate in that our workforce is very diverse. But it's ongoing education about cultures, cultural sensitivity, and We really do fall back on our values, which is providing compassionate care, showing respect, and I think that speaks across multiculturals. It's not just one culture. So I think that's what we instill in our nursing staff, so that we can meet the needs of various cultures.
Benchu, would you like to add to that?
I totally agree with that. I mean, we're so blessed that we have a lot of cultures in the hospitals, and we manage to relate to our patients, and we always go back to our missions and values, and that's really great because we have that already in our foundation. Is we look forward on doing that every day.
Anybody on this side of the table want to add to that?
No, you go.
I was going to say one of the challenges is the communication with different cultures, and so we have multiple different ways that we can do interpretation, and
Right.
So that's really important that we continue to have that support there for the different cultures that have different languages. And then the other thing is that we do training. There's culture, different culture. I don't want to say health-related, different ways
Sure.
that people approach their diseases and their healing processes, and we do have some training with that as well. So it's important to keep that up.
So the importance of having a diverse workforce in such a diverse region is clearly pretty important. Is it hard to recruit so that you have enough diversity on your staff so that it reflects how diverse the region is? And I put that question out to all of you.
If you're talking about the nursing workforce, we don't recruit specifically.
Not recruit,
based
that's not the
on-
right
okay.
word, but
on a
find
particular
talent,
culture.
I guess, is the...
But no, it really isn't, because right now in the peninsula here in Northern California, there's more nurses actually than there are jobs, because there was a lot of work that went into getting people into the nursing profession.
Yes.
And then we had a slowdown in the number of nurses leaving the profession. So we have a lot of nurses coming out of schools that actually can't get jobs.
Really?
So when we
didn't know that.
when we post a position, we have it filled pretty quickly by experience. So we also take new graduates as well, and then we do extended training with them. But we have not had any difficulty recruiting. Now, we don't recruit specifically for a particular culture, but because we live in such a multicultural community, we get a lot of different cultures that come in with that training.
Okay. So I have a question that's not on here, and it has to do with prevention. Because the best way to control costs, of course, is to keep people healthy, and the best thing to do is actually not have them come into the hospital. It's to stay healthy. Are you seeing a focus, because the costs are escalating every single year, more people trying to take control of their health and have a more preventative approach to healthcare, or is that not an accurate statement?
I think especially, let me go back, on an individual level, I'm not so sure. I think definitely it's become more of an industry standard with companies and having incentives for healthy lifestyles, or doing you get a discount, for example, on your insurance premium or your copay or whatever, or
Right.
your part of your insurance premium based on some outcomes that you have, like lab test outcomes or exercise or different things. So I think that's becoming more common, and I think overall, the community is becoming more aware of health and healthy lifestyles. So I think that has changed quite a bit in the last few years.
But it sounds to me like it's more from the employer and less from the individual.
I don't know,
Is
that's
that-
just my opinion.
I
but-
think it's hard for us to guess that, because we're taking care of the individual when they're at their sickest.
Right.
And so what happened before then, it's hard to know. What we do try to do is community outreach. We have the stroke run, just awareness, get everyone aware. Blood pressure testing,
Sure.
blood sugar testing, that kind of thing. just to bring the community to be more aware, and we get great turnout. So
That's great.
individually, possibly, but I'm not sure that we see that part.
Okay.
And the conversation's shifted. I mean, I think
Yeah.
even with this DCHS Medical Foundation, which we're connected with now,
And can you expand more on that?
that is it was the San Jose Medical Group initially, and then
Okay.
DCHS, and I'd have to know the exact. They created a legal entity whereby we could have a foundation of medical physicians
Right.
that are aligned with the Daughters of Charity, connected with the Daughters of Charity Health System.
Okay.
And so, and I'm on the operations committee for that medical foundation, and there is a lot of discussion around population health. So what that's going to allow us to do is look at some of these broader strategies of if we were to have physicians aligned with the hospital, we would be taking care of populations of patients.
Okay.
And then we could look at those populations and say, what do they need? And if that's diabetics, if there's a population, or if there's a lot of obesity or diabetes, how do we manage that in the community so that
Okay.
we're focusing less on all of our patients going into the hospital and waiting until they're very, very sick.
Right.
And we look at more prevention strategies. That is in place. It's not fully fleshed out at DCHS as it's going to be, but there definitely is that conversation, and that shifts again because we do need to keep people healthier, and we would want to see them not be in the hospital so much.
So, with regards to in our department, I'm in the orthopedic department. So
Right.
basically, before this patient goes to surgery, we already have them a teaching class. They have to come into the class. It's one of the requirements that they will know what to expect and what is expected from them on surgery day 1, or day 2 of surgery, and day 3 of surgery, after surgery. So basically, we already gave them like a pathways on what to expect. So they're giving them the idea of, you need to really you have all the control on everything. When you get into the hospital, surgery, then go home. But before surgery, we already told them about what to expect and plan ahead of time. Like maybe after surgery, they will need a skilled nursing facility or acute rehab center, depending on how they does. Or maybe they can just go home and they just need a home health nursing or home health PTOT. So, and then after that, when they get home, we try to make sure that we call them from the hospital to their homes, that they're okay, that they were able to understand the instructions, that they were able to make their appointments with the doctors, that they know what to do if things happen, like maybe you're running a temperature or the wound side is getting, feel really it's not normal, then which one to call. And we give them all the resources. So we try not to bring them back because of that one happened, and we try not to do that. So far, we've been doing great for that. I haven't seen a surgery patient that came back like 4 days or 3 days after discharge because
Sure.
of an infection. So,
Okay.
yeah.
Well, that's a great program. And I think it's again a nursing mindset to change from we send a patient home to we transition a patient to home and we call them the next day.
Right.
And I think there have been really very interesting stories that are coming out of thousands and thousands now of calls that we've been making throughout the system. Just finding that patients didn't understand a discharge medication, and because it's very hard to understand when you're about to go home from a hospital. There's a lot going on, so that check-in has really saved. Nurses can tell a lot of stories about where it saved a patient from having to maybe have a medication error or have an extra visit to a doctor, an emergency room, or a clinic because they didn't understand something when they left in a time of stress from the hospital.
So Karen, is that part of delivering the great, I guess, care experience for patients? Is that part of that?
Certainly. And getting back to the being culturally sensitive. So we had quite a few Hispanic males last year that came in with stroke and really trying to drill down what was the barrier. Was it lack of access to care? Was it a cultural preference where they felt that nothing was wrong with me? Because when people have strokes, it doesn't cause pain. You have other neurological symptoms
Right.
that may not always be so evident. And then trying to make sure that we also are giving that culturally specific care to remove those barriers, identify those barriers, make sure that translation is available, and also providing that follow-up phone call. And all of our patients that we treat with any kind of thrombolytic, which is a clot-dissolving medicine in the brain for ischemic strokes, call them once every
What's
month.
an ischemic
Lack
stroke?
of blood flow,
Okay.
to an area of the brain. We talk of it like as a heart attack, but you have no pain of the brain. It's a lack of blood flow to an artery in the brain, and it produces symptoms right away. And also we discovered through looking at a lot of our demographics for our stroke program that of our Asian patient population delays seeking treatment or care and may not be aware for other reasons, for other cultural barriers, to try to drill down exactly what are theirs, and using zip codes, being able to go out to those demographics and go to their farmers markets and go to their churches and provide stroke outreach information as a primary prevention to them in their language as well.
So we've talked about technology, we've talked about the patient experience, but I'm interested to hear a day in the life of a nurse. And so I'm going to start with you, Manchu, on this, but could you just talk about how the day looks for you and sort of some of the things that might make up a typical day?
Yeah, well, every day is just different. You just have to go.
There is no typical day.
There is no
Okay.
typical day for me because things might happen. It's just every day is different. So when I come to work, I always make sure that I'm really looking forward and talking to my patients and get things done. Like from day when I meet them during my first run, after I get my endorsement, usually I make my rounds and I talk to them. I use my whiteboard, and this is what we're gonna do today. In the whiteboard, by the way, that's our one way of communicating with our patients.
Okay.
It goes with the date, the time. The date, the room numbers, the doctors. What's the patient diet? What's the name of the nurse? What's the name of the physical therapy or respiratory therapist, OTs. What's the plan for today, that's my best highlight for them. I usually talk to them, okay, since I got the information already from the previous nurse, so I usually ask them, okay, what's the plan for today? If they don't know, hopefully they know, they know, of course, but
Right.
then I'll go to the chart of the patient and use the progress note and read in there and talk it to the patient when they come home. When I go make my rounds, I put it on my goal for today, that this is what we're gonna do today, and we're gonna accomplish it today before the end of the shift. If not, I will make sure the next nurse will be able to follow up with that. So my day basically is, as I said, it's different. So it depends on what's going on with my patients.
Okay.
It's really interesting. So I see it really. I'm so passionate about talking to my patient every time and see them really happy at what we accomplished during my shift.
Okay. Kelly?
I'm the director of critical care, so I would say that every day is an adventure and different. You might be helping a family through an end-of-life process in the ICU, or a very tragic event, and there may still be hope. So every day is different.
So I have a question. How do you leave that at the hospital? If you're having a conversation with somebody, the example you've given about, the ICU, you have to get in your car and go home. How do you separate the two?
I don't separate myself from being a nurse. I'm a nurse no matter what I'm doing.
Okay.
Even being mom, I'm a nurse. I do have an hour drive to get home, so I can decompress a little bit in that hour, but it's part of me. I try not to take I see a lot of good, and I take that with me, and I just try to, whatever negative, leave it.
Right.
Yeah.
So, in 10 words or less, not 9, not 11, 10 words or less, what's the best thing about being a nurse? Manchu.
Best thing being a nurse, it's really a gift and a blessing to me. A gift because not everyone can be a nurse.
Okay.
And it's a blessing for me because I have all the patience and I have all the compassionate and understanding to the worst situation that patient can have during that day, and I can absorb that and try to give them a better way of thinking about it.
Kelly, in 10 words or less.
Every day is an adventure, and I'm serious. It's never the same.
Okay.
Every day is different. But when you tell someone you're a nurse, you get automatic respect, whether you deserve it or not. So it's self-fulfilling in that way. But then you can also, this compassionate side of yourself, you're able to serve.
And Judy?
10 words or less.
Yeah, nobody's made 10 words
No.
or less yet.
We've all failed.
Well, nursing is an art and a science, and I love that you can do both in your job. And I feel that I'm doing valuable work, and I feel like I'm valued for what I do. And to me, that's a blessing to me.
Nancy?
Knowing you made a difference in someone's life.
I have the same thing. Yeah, making a difference, whether or not they may know it or not, or if it's something just writing an order or fixing something in the room or making the connection with the nurse or talking to their cousin. Yeah, making that connection, knowing that you made a difference.
Great. Thanks, everybody.